Hello, everyone. My name is Shakil Mohammed. I'm a pediatric neurologist and a clinician researcher at the University of Sydney and the Children's Hospital Westmead in Sydney, Australia. In this session, I'll be taking you through an approach to bilateral neuroimaging patterns in the deep gray matter nuclei of the brain, which is the basal ganglia and the thalamus. Before I start, I would like to acknowledge the traditional owners of the land on which the campuses of our hospital and the University of Sydney stand, and pay my respect to elders past and present. This is an overview of the talk where I've arranged it according to patterns of clinical presentation as either cerebral palsy-like presentations, acute presentations, or progressive presentations. Obviously, we won't be going through an exhaustive list in most cases, and I'll be providing this in the end. And I'll not be covering particular cerebrovascular syndromes apart from a couple of instances or tumors or unilateral lesions in detail. So starting out with chronic static clinical patterns, this is a case which illustrates such a pattern in a girl who we as clinicians would describe as having an asymmetric dystonic tremor, but with a generalized distribution and preserved intellect with a history from birth of a static clinical course. So this constitutes what we would commonly call a cerebral palsy. And in this instance, this child did have a history as well of neonatal jaundice. And this is depicted with the changes on the MRI, particularly clear on the 5-year-old scan in the coronal on the right, where you see hyperintensities on T2 weighted imaging in the globus pallidus, as well as in these nuclei, which are mesial to and just below the thalamus, called the subthalamic nuclei. It is more difficult to appreciate any abnormality at 2 years of age when the globus pallidus is transforming from being bright, as you see in infancy on the left scan, to gradually becoming iso-intense before it becomes hypo-intense compared to the putamen and caudate as we all grow older and the globus pallidus accumulates iron. This is an important age to be careful in either under or overcalling MRI changes in the globus pallidus. So this patient had kernicterus. Another similar pattern that you'll see is Another similar pattern that you'll see is in term babies who have hypoxic ischemic encephalopathy, where this different pattern of the pallidum instead of the globus pallidus, particularly the posterior or dorsal pallidum, along with the ventrolateral thalamus being involved, is characteristic. And in some cases, this also is associated with changes in the motor strips, as you see here. The thalami, without going into too much detail, consists of medial and lateral nuclei, and the pulvina and the medial and lateral nuclei are demarcated by this internal medullary lamina. This is a very nice paper from this year, which has shown that in this pattern of cerebral palsy due to term HIE, a pattern which includes global thalamic changes and the hippocampus is associated with a severe clinical phenotype, whereas a pattern that is restricted to the ventrolateral thalamus along with the putamen can be associated with a milder clinical phenotype. This is another child who has a static presentation, but this was acquired postnatally when he had a motor vehicle accident. So he's now in his early teenage, and this happened many years ago. As you can see, he has a right-sided tremor, only unilateral, which varies in frequency, is coarse, and it gets exaggerated by posture. So when we see this pattern, we as clinicians would call this as a cerebellar outflow tract tremor or a thalamic tremor, and some people may see as a resemblance to another entity called a Holmes tremor. Indeed, this is because these phenomena can occur due to lesions in either of the circuits that interact with the thalami, either from the cortex or from the dentate and the red nuclei. And this patient had changes in the contralateral thalami as a result of his injury, and we described him as having a cerebellar outflow tract tremor, which is summarized very well in this paper. Moving on to acute clinical presentations and how we negotiate this in terms of neuroimaging changes and reaching our differential diagnosis. This is an infant from one of my colleagues from the northern part of Australia, depicted in green, which is a tropical part in the Northern Territory. And this infant presented with an acute presentation with seizures, becoming rapidly sick, along with diffusion restriction in the ventrolateral thalami, as you see here. Indeed, suspecting meningitis and meningoencephalitis, he had a lumbar puncture which showed a mononuclear cell predominance, along with a high protein and normal glucose, suggesting a likely viral etiology, which was confirmed on PCR to be due to a regional specific virus called Meriwether encephalitis. And this conforms to the pattern seen in many of these arboviruses around the world, depending on where you work. A similar pattern may be seen with Japanese encephalitis in some parts of Asia, as well as in autoimmune presentations sometimes, which may be restricted to the basal ganglia, as in this case of autoimmune basal ganglia encephalitis. And sometimes in encephalitic presentations, this may also be seen with inflammatory disorders like fires or with other autoantibodies such as MOG, where you may or may not see other extensive changes. Respiratory viruses are particularly prone, but in some parts of the world, other differentials to be considered are listed here, particularly Mycobacterium tuberculosis, which can lead to a direct infective change or a vasculitis-related change in the neostriatum. This is another clinical scenario that you have to remember because the neuroimaging is quite an important clue. A 2-year-old who presented with acute encephalopathy, raised liver enzymes, and coagulopathy after an influenza-like illness, which was later proven due to flu A. And what the imaging shows is massive swollen thalami with variable hyperintensities in the putamen, the thalami, as well as in the external capsules and the claustrum. And many of you will recognize this as being representative of acute necrotizing encephalopathy, which is regarded as an inflammatory syndrome rather than a clear autoimmune or encephalitic syndrome. A similar pattern has been reported recently with COVID, as well as with other viral triggers, such as in this publication with dengue virus, where you again see this swollen thalami with variable hyperintensity is what has been called the donut or double donut sign, suggesting acute necrotizing encephalopathy. And the thalamic swelling is an important clue. Another acute presentation may be seen either with dehydration and changes in electrolytes, such as in this case, or sometimes with renal failure, where you may see changes with some swelling in the neostriatum again, along with this surrounding hyperintensities and thalamic changes. In some but not all cases, you may get a classical change called the battering appearance in the bones, as you see from this publication, which narrows down your differential to extrapontine myelinolysis. And as I said, a similar appearance may be seen with renal failure in hemolytic uremic syndrome, and these patterns can reverse over days, but sometimes can take several weeks. An important entity to remember in acute presentations is this of a delayed neostriatal changes and delayed extrapyramidal presentations after hypoxic injury due to drowning or strangulation, where the initial MRI may be normal, and 10 or 14 days later, you see this MRI pattern that correlates with clinical worsening and indeed a higher risk of mortality. In terms of thalamic patterns, as I said, I won't go into too many cerebrovascular patterns, but these are a couple of important examples. The one on your left is what you can see with deep cerebral venous thrombosis that may involve the vein of Galen that drains the thalamus, and this may be in a patchy manner, sometimes again with swollen thalami and hyperintensities in the paramedian regions. And in some individuals, you may have a presentation with an acute encephalopathy or excessive sleepiness, where you may see patchy asymmetric changes in the medial thalami again. And these individuals may be one of those people who have a unilateral supply to this part of the thalamus through an artery called the artery of Percheron, which can be picked up on angiography or MR angiography or CT angiography. This is a slightly different radiological pattern, as you see in this young child who was previously well and then presented with some confusion but more prominent abnormal movements consisting of some orofacial dyskinesia as well as hand coriform movements. And as you can see, he did not have neostriatal changes, but instead had hyperintensities in the globus pallidus that progressed over time to become near cystic. When you see this pattern, you have to think of a different list of differentials, and particularly the most common one to think about is methylmalonic acidemia that can be due to a number of monogenic associations. We looked at these patterns in this multi-center study and found that disorders that led to a predominant neostriatal pattern in pink were separate from those that led to a predominant pallidal pattern like methylmalonic acidemia in green. And there were other patterns that segregated in different clusters, such as vigabatrin toxicity, where you can get hypothalamus, cerebellar, and brainstem changes that clustered along with some mitochondrial disorders in this blue cluster, and another separate cluster of T1 variable hyperintensity that I'll go into later. Among the metabolic disorders that can present with pallidal changes, the other important ones to remember here are listed here, including Kearns-Sayre syndrome and also pyruvate dehydrogenase deficiency. But there is a longer list of rarer differentials that I will list out in a link at the end of my talk. In terms of the neostriatum, we have looked at some encephalitic examples, but what about neurometabolic disorders that have a predilection for the neostriatum? An important one to remember is biotin thymine responsive basal ganglia disease. And don't forget this pattern, it's very rare, but this is a treatable disorder and outcomes can be very good if treated on time. Again, you may see swelling of the neostriatum along with this very unusual but typical cortical highlighting either on T2 weighted or as well as diffusion weighted imaging. Another pattern for a treatable disorder not to forget is this mixture of hyperintensity and lucencies on T2-weighted imaging in the neostriatum. And this may sometimes appear in a more diffuse manner with hyperintensities with globus pallidus changes that are not as prominent but can accompany thalamic and brainstem changes. And these are representative of Wilson's disease. Again, a treatable but rare disorder, more common in some parts of the world, clustering together in this putaminal pink cluster. These are again just some visual images for you to imprint rather than go into detail. I'll particularly highlight the two on the right side, which is MEGDL, that is a metabolic disorder associated with mitochondrial dysfunction, as well as this example of a mitochondrial encoded gene with mitochondrial dysfunction. And what I want to highlight is this neat demarcation of spared regions of the putamen, as you see here, as well as more classic in MEGDL, where you may get this middle areas of neosymmetric sparing. And these are often a clue towards mitochondrial disorders, though there is a few other differentials such as interferonopathies, biotin responsive basic ganglia disease, or Wilson's that may have also similar regions of sparing. This pattern of MEGDL is particularly important to remember as can be almost pathognomic. In terms of the thalamus and metabolic disorders, while we are talking about metabolic differentials, again, as you saw, the various metabolic disorders that involve the neostriatum in particular can involve the thalamus, but I'm just listing these three here again for remembering as more important differentials. Gaines-Sayre syndrome, which we have seen before, that can also involve the white matter and the dentate, and this takes out the pallidum rather than the neostriatum. Lactic acidosis with thalamus and brainstem involvement due to EARS2 mutations, where there can be an acute clinical presentation with a dramatic radiological change, as you see here, and there can be incomplete, if not near complete recovery in some cases with time, both radiologically and clinically. Among the mitochondrial disorders, if you get thalamic and white matter changes, an important differential to remember is complex 2 deficiency compared to complex 1, 4, and 5, which may have a more neostriatal involvement, and this is associated with succinate dehydrogenase deficiency. Let's move on to some other patterns which are relapsing, remitting, and then progressive. So this is one of our cases who presented in early childhood with chorea, but then had stroke-like presentation separated by many years, as you can see with contralateral imaging changes, sometimes involving the deep grade nuclei. And this is an MRI change that has been recently described only in a few cases with a normal monogenic association, which is the reason I mention it here as one of your differential for stroke-like presentation spread over time, associated with a gene called ROBTB2. This is from a publication of a young person with relapsing chorea. And whenever you have this history, even if someone had been previously labeled as chorea gravidarum or Sydenham's chorea or antiphospholipid associated chorea, always remember to consider MR angiography as well as a cardiac screen, as moya-moya disease or ongoing cardiological problems can be associated with this clinical pattern of relapsing chorea. Episodic movement disorders, I won't go into too many details. Most commonly for us clinicians, the neuroimaging is often normal in these cases. You have to think about neuroimaging when there may be some clinical red flags as listed here. And these are some patterns that may be seen, such as globus pallidus changes in pyruvate decarboxylase deficiency, SSADH deficiency, GABA transaminase deficiency with thalamic hyperintensities, ECHS1 deficiency, again a treatable disorder where you can get this pallidum dominant changes with episodic, particularly exercise-induced dyskinesia, and secondary paroxysmal movement disorders due to demyelination or with basal ganglia calcification. Basal ganglia calcification is important as there is a variety of monogenic associations that have been recently described with paroxysmal dyskinesia with basal ganglia calcification. And this is something to consider in your undiagnosed cases with episodic movement disorders. While on the subject of calcification, I'll just mention a couple of other interesting new additions. One with on the left side, where this is from a case who presented with acute hemiplegia but had bilateral basal ganglia calcification. And this is a gene which has been recently added to the so-called FARS disease association with monogenic causes. And this gene is called MYORC, which can also present with paroxysmal movement disorders. This pain on the right from this publication in Brain recently is a new monogenic association described with acquired microcephaly, epilepsy, but also with a spectrum of movement disorders and migraine, adding to the differential of migraine overlap syndromes that can present with alternating hemiplegia or familial migraine or hemiplegic migraine. And calcifications in the brain, not particularly the basal ganglia, can be an important clue. And this is, as I said, a newly described gene called claudin-5, which can cause increased episodic permeability of the blood-brain barrier. So moving on to the last section, which is progressive clinical patterns. This is a sequence of imaging changes, 3 MRIs, and the pane B is the CT scan from a preschool infant who had a progressive illness-related stepwise course, whereby he regress with minor illnesses throughout the first 2 years of life. The imaging shows increased susceptibility in the globus pallidus, very odd for a 2-year-old. But in addition, there is neostriatal hyperintensities, as you see in pane C, and some atrophy of the dorsal putamen, but interestingly also CT scan calcifications. When you see these combination of changes, you have to think about a group of disorders called interferonopathies, and the clue in this child was a high CSF neopterin, as has been outlined in this publication, which included this patient along with some others. And this is an important condition to remember because there may actually be a useful intervention in the form of medications called JAK inhibitors. Another pattern that may be seen in progressive clinical courses is this, where you may see subtle hyperintensity in the dorsal putamen, sometimes with increased susceptibility accompanying the putamenal change, as you see in the right pane. And when you see this combination of putamenal hyperintensity with susceptibility, you can think of the interferonopathies due to calcification, but another important differential to think about is gangliosidosis, which can present at various ages throughout childhood or early adulthood even. Another important neuroimaging correlate not seen in these images, but can be seen in some other individuals with gangliosidosis and other storage disorders, is this appearance of dark thalami, which can be a clue towards lysosomal storage diseases, as well as some other neurometabolic disorders that have been listed in this publication. This is a video from a publication in movement disorders of a young boy who had generalized dystonia, and also dyskinesia, and he had a very unusual gait that has been described as the cock walk type of gait. In terms of neuroimaging, this patient had a neuroimaging that conformed to this last cluster that I had alluded to before, the purple cluster, with very prominent T2-weighted hyperintensities in the globus pallidus. And this patient turned out to have changes in a gene called SLC39A14, which is the second manganese transporter being described after an initial one was described called SLC3810, where you may get more diffuse hyperintensities in the neostriatum as well, along with liver disease and polycythemia. In this gene, you don't get the liver disease and polycythemia, but these are both manganese transporters. I want you to remember this neuroimaging pattern because there is nothing quite as bright as manganese on T1 weighted imaging. You can get T1 weighted hyperintensities sometimes in other causes, such as here in this unilateral pattern, or sometimes in bilateral pattern with hyperglycemia, which is something to remember as a differential in acute presentation. In terms of progressive patterns, another pattern that you may see is abnormal susceptibility weighted imaging. We have seen this in the gangliosidosis case before, but the more classic disorders are what are known as neurodegeneration with brain iron accumulation. And I just listed some of these for the sake of completion, though we won't have time to go into details. And these are the classic brain iron disorders, such as pantothenate kinase associated neurodegeneration with the eye of the tiger sign, though if there is calcification in this area, there may be just diffuse increased susceptibility rather than the eye of the tiger with this hyperintensity of the globus pallidus. Perhaps the most common of these disorders, which is called BPAN due to WDR45 gene associations that can have a Rett-like syndrome presentation with epilepsy in childhood and then movement disorders in teenage. Earlier on, there can be T1 weighted hyperintensity. It's what is called the halo sign in some cases in the substantia nigra, along with prominent nigral susceptibility. MPAN or mitochondrial protein associated neurodegeneration, where you may get this hyperintensity in the medial medullary minor, neuropsychiatric or acute extrapyramidal presentation that can be in teenage or early adulthood, and Pla2G6 associated neurodegeneration, where apart from susceptibility, which is not universal, and another important clue can be cerebellar atrophy along with cerebellar gliosis and hyperintensity. Abnormal susceptibility, other than the neurometabolic disorders I mentioned before, has a wider range of differentials, particularly monogenic differentials that are being added day by day. The two on the left, KMT2B and BPS16, are important for clinicians and radiologists to remember, mainly because these are emerging as the more common monogenic dystonia genes that have been recently described, and these can have abnormal susceptibility patterns in the globus pallidus as described here. Finishing off with the last couple of slides, there is a pattern that's often alluded to as striatal necrosis, though to be honest, this is a pathological term, and the radiological clues can sometimes include atrophy when you have sequential images along with cystic changes, when you can confidently say that this may correlate to necrosis, but you may allude to these as bilateral striatal lesions. Again, these can have a variety of acquired as well as monogenic causes. These can be a sequelae of many of the inflammatory or neurometabolic syndromes that we talked about before after the acute insult. In terms of monogenic causes in childhood, though rare, juvenile Huntington's disease is often missed, and therefore I've highlighted this where you can get prominent caudate hyperintensity along with striatal atrophy with time. And there is a number of monogenic causes such as this listed here called PDE10A, but indeed the list is exhaustive and I'll provide this in my notes. When you do see these lesions, what I think is more pragmatic to remember is, are you missing a treatable disorder, such as an inflammatory or autoimmune disorder, or a neurometabolic decompensation with toxins or myelolysis? Could it be Wilson's or biotin? And you've seen the clues to those patterns before. And then in terms of metabolic disorders, you have to think, are there any clinical clues such as chorea with PDE10A, which may suggest a particular monogenic disorder, calcification with interferonopathies? Could it be metabolic and not mitochondrial, such as open operculum, along with neostriatal changes in glutaric aciduria? Could it be mitochondrial? And in that case, you may get lactic acidosis. You may sometimes get thalamic changes along with basal ganglia changes, or you may have other clues such as brainstem changes or spine changes in LTBL or LBSL. As I said, there is a whole host of neuromonogenic dystonia syndromes that are not particularly recognized by the clues. I've just mentioned this pattern because there are some of the mitochondrial disorders and some other monogenic disorders, such as the one listed here, where you can get an acute decompensation with stress, which may indicate almost a consideration of an immune, inflammatory, or metabolic disorder. And you can also get spinal cord changes, such as in this case described from our institution, who had early childhood onset of neurological problems, dystonia, and she used to decompensate every time she had a febrile illness. And this is a new genetic association with a gene called EIF2AK2 that has been described either with a static phenotype or with this stress-associated decompensation. The only reason I mention here is not to confuse you with just another genetic differential, but to open your mind to the possibility of the paradigms that monogenic causes can mimic inflammatory or acquired causes in both the clinical course as well as the neuroimaging patterns, and have to be considered in your differential list. As I said, I won't be going into tumors, but I'll just mention these last two couple of images before I finish off, that basal ganglia changes may sometimes be seen as with hematomas in NF1, as well as this massive swelling, which may be near symmetric, can be representative of thalamic gliomas and sometimes has been misdiagnosed as inflammatory presentations. Alluding to the paper I mentioned before, we present here an approach to bilateral basal ganglia changes, and you have to start off by thinking what data set, whether T2, T1, or susceptibility shows the change, and then work your way through to seeing, is it a striatum or pallidum dominant change? If you have T1 weighted hyperintensity, is it patchy or diffuse? And if you have susceptibility, where is it? And are there any of these associated features? This is a QR code that links to a previous version of this talk, but which I'm mentioning here because it has got a wider list of the differentials than what was possible to go through today. And this is a link to our paper on the basal ganglia imaging patterns. I acknowledge all the people who have helped me over the years, with not only with this paper, but with subsequent cases and my clinical research. Thank you.